It's helpful to think that there are three sort of major pathways that people traverse as they're dying in old age. One is a relatively predictable pathway where you get an overwhelming illness diagnosis, something like lung cancer or renal cell carcinoma, that very few people escape. You may well be able to be treated for a while and live a little longer, but at some point the illness will be overwhelming. The person will take to bed and pretty much die within a few weeks or months, a relatively short period of time. Families can rally. Most families have enough resources to support a person through that course. That was the image we had in mind for hospice care. And it's the image we have in mind in almost all our movies. So, somebody gets a bad diagnosis, does a few foolish things, a few meaningful things, pulls their life together, and dies in a sort of predictable way. That's a minority trajectory. A second minority trajectory, but a little more people, is people who have a problem that we can partially rescue with medical treatment. So they come into the hospital and they're terribly sick, and we manage to pull them through and get them back to a stable condition. And then they sense that they're waiting for something even worse to happen, but in fact their heart's still getting weaker, or their lungs are still getting worse. And they will have more exacerbations, more trips to the hospital, and usually die in one of those exacerbations. So it'll be a sort of dramatic thing. They've been doing kind of well for the last month, and then all of a sudden they're in big trouble and they're going to the hospital and they go on and die, and people will say, well, he died suddenly. But 2 weeks earlier he was unable to climb the steps. He's been on oxygen for ages. It's that the dying itself is sudden, but the course is one of serious illness. And then there's the long-term frailty, which is now the majority way to die in old age. So people get multiple chronic conditions, essentially accumulate problems. So they've got a weak kidneys, and they've got a weak heart, and they've got poor vision, and their hearing's going bad, and their joints are aching, and many, many little problems, each of which one by one can kind of at least partially be treated, but the sum of them makes a very constrained living. And that trajectory sort of inches along with people sort of living constrained lives, but no one quite gets around to saying, this is going to end up with a death. And how do you want that to happen? But we can't tell whether it'll be this year or 2 or 3 years in the future. It's quite uncertain. So these are the people who, when they get flu in the winter, they die in large numbers because they really don't have much reserve, or they go off their diet, or they stop their pills, and all of a sudden they're in terrible trouble. But 2 weeks earlier you wouldn't have known that there was anything going to happen to mother. So those three trajectories, I think, help us design services that support those. So the person who's dying in a pretty predictable way needs hospice-type support, lots of aggressive nursing care, lots of support to the family. The person with an organ system failure that's bringing them in and out of the hospital needs a standby plan for the one that becomes overwhelming, and lots of good medical support for those exacerbations. But the person who's living with frailty often needs much more hands-on care. The direct caregiver that comes in and gives a bath, the person who helps spoon feed, the person who helps keep the house clean, helps keep people in the community longer and not having to go into a nursing home. So it's the sort of ongoing support that goes for months and years, and that's the one that relies most on family. So the family caregivers are the biggest component of supporting people in this phase.